So welcome again to our Lunch and Learn webinar. The topic today is systematic reviews of diagnostic test accuracy. And I'm very, very happy to have Mariska Leeflang here today, our speaker. And I will just briefly introduce Mariska. She is Associate Professor in Clinical Epidemiology at the University of Amsterdam. Her involvement in Cochrane started in 2004 in Freiburg, with one of the first meetings to develop a handbook for diagnostic test accuracy reviews. And since then, she worked on the development of methods for evaluations of medical tests and methods for diagnostic systematic reviews. And Mariska is one of the conveners of Cochrane's Screening and Diagnostic Test Methods group. So again, I'm really happy to have you here today, Mariska. And now it's your turn.
Yeah, thank you for being here and to be virtually back in Freiburg, which is really nice after, about 20 years. As already introduced, my name is Mariska Leeflang and I work here in Amsterdam. And I started my research career within Cochrane. I have no financial conflicts of interest, except that indeed I'm a co-convener for the Cochrane Screening and Diagnostic Test Methods group. I published several guidance documents on doing these kind of systematic reviews, and I'm one of the editors of the Cochrane Handbook for Systematic Reviews of Diagnostic Test Accuracy, which was officially launched last September. So after after almost 20 years of work, the handbook was finally ready. So up until now, that has joined me my whole career, basically working on the Cochrane Handbook. I also, so it's a presentation, it's 1 hour lunch and learn, and there is some room for questions, so I have been asked to keep the presentation not too long. So if there is any information you miss and there's not enough time to answer them in the questions, then of course I refer you to the handbook. But let's start with diagnostic tests and diagnostic test accuracy, because we are now talking about diagnostic test accuracy, but if you talk about the evaluation of diagnostic tests, then there are, roughly speaking, also in the regulations within the EU, for example, there are roughly speaking 3 phases of test evaluation. The first one is more the technical validation or the analytical performance. Do these tests do what they promise to do? The second phase is clinical performance. So is the test able to distinguish people with a certain condition from people without that condition? And the last one is clinical utility, answering the question, if I use this test, is it indeed profitable for those who are tested? In this presentation, I completely focus on the middle phase, so clinical performance, also explained as diagnostic test accuracy. But please remember that the evaluation of diagnostic tests encompasses more than just diagnostic accuracy. There is on one hand worry about the validity of tests, and on the other hand there's the worry about the utility or the effectiveness of testing, which I will not address today. As said, so we focus on diagnostic test accuracy, and that means that we focus on outcome measures like sensitivity and specificity. Also predictive values, maybe likelihood ratios or odds ratios, but the analysis are completely centered around sensitivity and specificity. And here you see the 2x2 table, and to calculate sensitivity and specificity, you need to dichotomize the test results and you need to dichotomize the target condition, which there's a lot to say about, but if you work with sensitivity and specificity, then this dichotomization is necessary. You also see on the left-hand side what we call an ROC curve. or a receiver operating characteristic curve that shows the relationship between true positive test results and false positive test results. And I will come back later to such a graph in the context of meta-analysis. The steps in a diagnostic systematic review are basically the same as the steps in an intervention review. And here I have listed the 5 most, the biggest steps, so to speak, and the steps that I will discuss today. So question formulation, search and selection, quality assessment, the meta-analysis and interpretation and conclusions. Of course, these steps can be divided in a lot more steps, but in principle, these are the most important steps. And in principle, you follow exactly the same steps as you would follow for intervention reviews. And that starts with question formulation. And as we all know, question formulation is really important because it drives the rest of your systematic review. It drives your search and selection criteria. It drives data extraction and quality assessment. It drives the meta-analysis and it drives the interpretation. And the overall question in a diagnostic test accuracy review is, does the index test sufficiently well discriminate between people with and without the target condition? The index test here is the test that you are interested in, and there may be multiple index tests. And the target condition is the disease that you are interested in. But we use the term target condition because it's not always, because disease is a rather vague term, and target condition is usually more specific. So it contains the word sufficiently, and that's of course subjective, but it does depend on the intended role of the test. So not all tests, so it depends whether the test has a triage role, so to sort which patient should be referred for further testing and which patient should be sent home, or whether it has a confirmatory role, really to determine which patients should be treated and which patients may be further followed up. So whether what sufficiently well is depends on the intended role of the test. And it also depends on what the purpose of the test is, whether the test is fit for purpose. And we need to keep in mind that this question on this slide is formulated for one single index test, but that many of these systematic reviews actually have a comparative question. And then the question may be, which test is better fit for purpose, or which test is more sensitive, or which test is more specific. To be able to answer that question, you need to know what the purpose of the test is, of course, and where in the whole clinical pathway the test is being used. In intervention reviews, we use the PICO to formulate the question. And for diagnostic questions, the PICO has some complexities or some difficulties. And for that reason, within the PRISMA group for DTA reviews, we decided to not use the term PICO, but to use the term PIT. And the reason for that is that the P of patients is not only about the patients. So, of course, you want to know what is the relevant patient groups, who will be tested in practice, in which healthcare setting, so is it in primary care or in secondary care, and what are the follow-up steps. So this information is important, and also what are the preceding steps. The index test, the I, which does correspond with the I in PICO, may also refer to any relevant comparisons. And one of the reasons that we chose PIT is that the C in PICO is often confused for the reference standard, while it's actually talking about comparisons between different index tests. And then the target condition. So of course, what is the target condition, but also how is the target condition established? What is the reference standard that is used to establish the target condition? And why is that reference standard removed from our acronym is because, because we understand that there is not such a thing as a gold standard, and that completely focusing on reference standard may give an unfair idea of truth. Well, actually, we want people to think about what is the target condition and realize that the target condition is measured in some way, and that some way is the reference standard. So it's all a little bit more complex than for intervention reviews. I briefly mentioned the clinical pathway, and here the clinical pathway is shown in a scheme, in a schematic illustration. And usually patients come with signs and symptoms first to primary care, and then they are referred either for no further action or some further action. They are referred for secondary care or even more specialized settings. And why is it important to know this setting? That's for two reasons. The first reason is that exactly the same test used in primary care and in secondary care may have a different performance. So a test may have different sensitivity and specificity when it's used in primary care compared to when it's used in secondary or tertiary care. So you need to know in which setting and among which patients the test is used. And the other reason to know the clinical pathway is that because the relevance of sensitivity and specificity and the importance of false positives and false negatives depends on the consequences of testing. And to know the consequences of testing, you need to know what the next step is after testing. So if you have false negative test results and you send them home without ever looking after those patients, then you want those false negative test results not to include patients with a lethal disease, for example. Well, if the next step for the negative test results is further testing, then maybe you're less worried about false negatives. And the same for the false positives. If the next step is treatment with severe adverse events, then you don't want too many false positive results. Or if the next step is an invasive next test, you don't want too many false positive results. But if it's a confirmatory test or it's a relatively easy treatment, then you're less worried about the false positives. So you need that clinical pathway and you need information about that. And that's important to describe and certainly in Cochrane systematic reviews of diagnostic test accuracy. So two examples about question formulation. One, is serology sufficiently specific to serve as triage test for Lyme disease in general practice? Or a comparative question, is a modified two-tier test strategy for Lyme disease sufficiently accurate to replace standard two-tier testing in secondary care? And then you see the P, so the patients or the setting, so general practice, or you could say patients with certain symptoms in general practice or in secondary care. The I is the index test and the role of the index test and also the comparator test. And the T is the target condition. And you see that here there is no reference standard in the target condition, but of course you need to make the reference standard explicit. Okay, that brings me to the second step, and that's search and selection of diagnostic accuracy studies. Oh, I need to go back there. Which is Similar for search and selection for intervention reviews. Also, you use multiple synonyms and multiple terms, both for the target condition and for the index tests, and if necessary or appropriate, also for the population or the setting or the reference standard. And one warning is to be careful when you use search filters. But actually the most important message is at the bottom of this screen. So if you develop the search for a diagnostic test accuracy review, expect about 2,000 to 5,000 titles and abstracts to screen. That is really not so many. So sometimes you have to set your expectations, or you have to calibrate your expectations if you do these reviews. And of course, best is to go to an information specialist who can help you with these. Now, what kind of studies are we looking for? Preferably, we are looking for studies that start with one sample of patients or participants that more or less form a homogeneous group, that follow consecutive enrollment with relevant eligibility criteria. Preferably, at the moment of applying the index test, the researchers do not know the disease status of these patients. So you perform the index test blindly without knowing whether the patients do or do not have the target condition. That's the next step, the verification step. And the verification is done by the reference standard, which should be sufficiently reliable. And only at this verification step, you learn who has the target condition and who has not the target condition. And why do I stress this? Because what we sometimes see is the inclusion of studies that separately assess the sensitivity in people with the target condition and specificity in people without the target condition. And if the people, with the target condition and without the target condition come from different populations, then actually your sensitivity and specificity may not be representative and may be biased. So ideally, you start with one group of participants who are representative for those patients who will undergo testing in practice as well. And then after verification and after you did the index test, the 2x2 tables can be made up true positives, false negatives, and true negatives. So this is the kind of studies that you're looking for. But searching and selection is sometimes complicated because the 2x2 table data that you need may come from several different study designs. So on this slide, you see the ideal study design, but there are a lot of different study designs that may provide you with at least with the right data to make the 2x2 tables. But you have to question yourself then, okay, are these studies, do they have risk of bias and are they representative? In case of comparative accuracy questions, ideally you would like to include fully paired or randomized paired studies that directly compare in one study the accuracy of one test with the accuracy of the other test. So here we compare the accuracy of MRI testing with the accuracy of CT. So ideally, all patients would undergo one test and the other test and the reference standard, but because it may not be feasible for everyone to undergo MRI and CT, the other option is to randomize patients for MRI and CT, but make sure that everyone undergoes the reference standard. I will skip this for now. Search and selection can be done automated. there are several supporting systems that may rank titles and abstracts according to the probability of being relevant. For example, EPI Reviewer, EPI Reviewer, AS Review, Ryan, and there are several more. So far, these systems do not always add a lot if it's small one-off reviews, especially not because most of them are not trained on diagnostic accuracy studies. Although the field is developing rapidly, so it may be worthwhile to just give it a try. And especially if you have large reviews or living reviews, it may be worthwhile to have a look. Okay, that brings me to the next step, data extraction and particularly quality assessment. And for quality assessment, we have a risk of bias tool or a quality assessment tool called QuADAS2 and an extension to that for comparative studies called QuADAS-C. Both tools are divided into 4 domains. A domain for patient selection, for index tests, for reference standard, and flow and timing. And for each of those domains, we check whether there is possibility of risk of bias. So was there consecutive enrollment? Was the right study design used? Were there appropriate eligibility criteria? Were index tests and reference standard blinded? Was there a pre-specified cutoff for the index test? And was the reference standard likely to correctly classify the disease? And then there are some extra items like an appropriate time interval between index test and reference standards, partial verification, differential verification, and missing data. And for QuADAS-C, we developed QuADAS-C because even if QuADAS-2 for 2 or multiple tests would indicate that there's no risk of bias, then the comparison between the 2 tests may still be biased. So if you are doing a comparative diagnostic accuracy review, then you should use QuADAS-C. Besides looking at risk of bias, we also look at concerns regarding applicability, and we do that for the 3 domains: patient selection, index test, and reference standard. And why do we stress that? Well, as I already explained, that one test may behave differently in different settings, so you need to take that into account also when you assess methodological quality. And QuADAS2 is built up the same way as most risk of bias tools nowadays. So with signaling questions, and then based on these signaling questions, you make a judgment whether there is bias or not, or low risk of bias or high risk of bias. Okay, then we are with a meta-analysis. And the meta-analysis is, I think, the most different part from intervention reviews, because it focuses on 2 outcome measures, sensitivity and specificity, which are negatively correlated. So A, they are correlated, and B, they are negatively correlated depending on the positivity threshold. Sensitivity and specificity are typically heterogeneous, and that should be taken into account if you do a meta-analysis. So we use hierarchical regression models. These are multi-level, so they allow for within and between study variability, and they allow for correlation between diseased and non-diseased people. They're logistic regression models, so they correctly model sampling uncertainty. You don't need any zero cell adjustments, and they're random effects models. And very important, these models model the relationship between the true positive results and the false positive results, both for diseased and non-diseased. So they, at the same time, evaluate sensitivity and specificity. There are roughly 2 ways to do that. And one method results in a curve, as you can see on the left-hand side. And the other method results in a summary estimate for sensitivity and specificity with a confidence region and or a prediction region around it. One major category of models is the bivariate model. So bivariate means that there are two dependent outcome measures, sensitivity and specificity, or actually logit sensitivity and specificity. So this model gives you the mean of the logit sensitivity and its variance, the mean of the logit specificity and its variance, and it gives you the correlation between sensitivity and specificity, which is important because the two are correlated according to, well, as you see in this ROC plots. The other model is the hierarchical as summary ROC model. And it gives you a curve. It gives you the mean natural logarithm of the diagnostic odds ratio plus its variance. It gives you a mean proxy for the threshold of the test, and it gives you the shape of the curve. Now, these two models look very distinct and different, but if you do not add any covariates, they're basically the same. So you can use the HS-ROC model to give a point estimate of sensitivity and specificity, and you can use the bivariate model to give a summary HROC curve. But the underlying philosophy is different. So for the HROC curve, the underlying philosophy is every test is a continuous test, and every test has some sort of threshold effect. Well, the underlying philosophy for the bivariate model is every test is followed by a decision, and that decision is often binary. So you need a sort of binary measure to give an indication of the consequences of that decision. And that is the underlying philosophy for the bivariate method. As I said, sensitivity and specificity vary a lot. There may be differences in setting and population that cause variation between studies, differences in how the test was conducted, differences in reference standard, risk of bias. So this is an example from one of the meta-analyses that I have been involved in. And every symbol that you see represents the sensitivity and specificity from one study, and the different colors represent different tests. And you see the vast heterogeneity. So sensitivity varies from 0% to 100%, and specificity varies from, well, what is it, 10% to 100%. And they vary over the whole range. And this is something you can typically expect if you do a diagnostic test accuracy review. So you need to deal with that. And that brings me to the last point, and actually the last slide, and that's interpretation and conclusions. So we started with a clinical pathway and a clinical problem that was translated to the review question, which drives the whole research process or review process. And it also gives you a context to explain what the results mean. And within Cochrane, we put very much emphasis on that explanation of what do the results mean? What does it mean for practice? What happens to the false positives? What happens to the false negatives? And how many false positives and false negatives can you expect if you apply this test in clinical practice? That ends in a take-home message that is again translated into implications for practice, policy, and research. That is, in a nutshell, how a diagnostic systematic review is done. And that's the end of this presentation. And I wonder if you have any questions.